Hello, everyone. Today is August 13, and we are very happy to be here. We have friends from Bolivia, Paraguay, Brazil, of course, Argentina.
Thank you, Arturo. Anthony, you present a great video here, but we are talking every time about anatomy on the macular hole, close the macular hole or not close the macular hole. What about the visual acuity of this patient? How much visual acuity did you recover? And if you use in your routine practice some kind of functional studies about microperimetry or multifocal ERG to evaluate the post-op, not only the OCT.
It's an amazing question, Doc.
Visual function, including visual acuity, microperimetry, and multifocal ERG. Great point. Thank you, Anthony.
So thank you, Marcelo. Let's move to the next case.
Perfect. The next case, thank you again. It's a great honor to be here. Thank you, Jorge, again. Thank you, Rishi. And thank you, Debbie, for all your support in Retina World Congress, all organizing. I'm going to present my friend Nelson Sabrosa from Brazil, from Rio de Janeiro. Nelson Sabrosa is a great vitreoretinal surgeon. He made a vitreoretinal fellowship at Murphy's in London, in England. And now he's in the Department of Retina in Gamboa, Rio de Janeiro in Brazil. Nelson, your time, all yours. Thank you for joining us. Nelson, great case. For example, I think you use Avastin as a pre-op in this case because we can see how the members of the plant were very dry. So these are the typical Latin American patients that we have in our hospitals, public hospitals, with no treatment, no PRP, and you did great. What's your opinion about early vitrectomy and also to do the Avastin as a pre-op? No, we spoke about the PRP before.
So we tend to do
we need to operate this patient before. So the early vitrectomy now is the standard care about the diabetic in the PDR patients. And I agree with you talking about the bimanual technique, only using viscodissection, as Rishi said, or you need bimanual technique to maneuver, to make all the plans with scissor, with the forceps, with the vitrectomy probe, with 27 gauge, with the duty of the cycle. We have now in the operation room very nice toys to manipulate, to visualize, to magnify the image, and to stain the vitreous and the membranes. What's the opinion on the panel, for example? What's your experience, Dr. Starr, Matt, or Pablo from Paraguay? What's your opinion? What's your opinion, please?
Marcelo, you want to do any comments?
I think it was we are on time, Arturo, so we have to begin just to be on time. But just remember, Nelson showed us a great PDR case with early vitrectomy by Malon on all the choice we are having now with the bevacizumab in the pre-op, and we are going to agree here in the panel what we have to do now with diabetic patients, especially in Latin America, putting silicone oil as a tamponade. And also, Pablo, you're very lucky because sometimes this kind of subretinal hemorrhage can organize and in clots, and you can put perforated liquid, and maybe you don't be allowed to move all the blood that you made it. So sometimes the perforated is helpful, but sometimes the clots are still there using perforated. So you need maybe to use TPA or maybe to use in a new retinotomy to drain the vitreous, the subretinal hemorrhage. And also you're lucky because now, for example, in Argentina, it's very for us. It's easy. It's easier to get 1,000 or 1,300 centistokes silicone oil. We don't now allowed to need because it's more difficult to get 5,000 centistokes because 5 centistokes maybe in some case it's difficult to put and also it's difficult to get out from the eye. So now we are preferring to use 1,000 centistokes silicone oil.
In this case, if you have both, you will prefer 1,000.
1,000. I think the surgery is not because of the silicone oil. I think the surgery was successful because you drain the subretinal hemorrhage, you make some laser over the tear, and the retina is attached. The silicone oil is not going to give you the final solution of the case. So thank you again, Pablo. Great presentation, great discussion. We have to move to on our own time to our last speaker, Dr. Matt Starr from the USA, representing the Beat Buckle Society and the Mayo Clinic from the USA. Matt, your time. Thank you for joining us. Great, Matthew. It's a great case. We can discuss, I think we can discuss in 2 parts. First of all, the trauma solution and then the cataract solution you made. So first of all, I want you to listen to our panelists. Marcelo Murillo, your opinion, and Arnaldo next, your opinion. Matt, what kind of IOL did you decide to put? You put the 3 pieces IOL or just one piece?
Thank you so much and have a great Sunday.
Thank you.
Thank you.